This is with pleasure. I would like to present my colleague, one of the surgeons, one of the best thoracic surgeons I have met in my life, and was actually one of the cornerstones I was depending on in establishing my third space endoscopy as well as anti-reflux procedures. Dr. Ashraf Maghrabi, he is a former head of society of surgical society, and he is, with no further ado, actually giving us a great talk as the first surgeon participating in our sessions today. And we will have an interesting discussions, and he will enlighten us about new novel procedures that he's been doing for the management of anti-reflux. Dr. Ashraf Maghrabi, thank you so much for joining us today, and it's my pleasure to introduce you as well.
Okay, Assalamu alaikum wa rahmatullahi wa barakatuh. Good day, everyone, and thank you so much, Ahmad, for this nice introduction. Um, so my talk for the coming 15 minutes, I decided to do a very quick video about the LINX procedure, which we commonly use now for reflux. And I have to start the presentation actually that there is something that I have to admit. I consider myself also lucky working with Ahmad in the same center lab, but working with Ahmad is actually a little bit difficult, and I'll tell you why. Um, there is no secret. So first of all, I mean, Ahmad, of course, like is sharp-looking guy, and I tried to beat him with that, and I found that plastic surgery is really costly. So, and I found myself too old to be to study gastroenterology again, and to learn the 200 procedure that Ahmad is expert and master. So I said, what can I beat Ahmad with? So I decided, well, Ahmad read a lot. So I decided to go and use this panel to try to discuss with Ahmad, and I will try to prove to him that surgery is better than what you, Ahmad, do and PPIs. And I don't want to tell you what I found, but I think I'm just gonna go with the flow. So for the coming 10 minutes or 5 minutes, I'm just going to talk about the LINX procedure. I won't take much of your time about that. So it's one of the procedures that, of course, the LINX is the MSDA that's actually manufactured by Johnson & Johnson. And I'm actually a MENA proctor with this procedure to train surgeons in different hospitals, but I receive no disclosure for that. So the presentation will be divided in half. The first half will be about the LINX. The second half will talk about the anti-reflux surgery. Does it actually prevent cancer? Um, our dear colleagues and expert gastroenterologists talk a lot about this already, and we know GERD actually is a bad thing, and it can cause Barrett's esophagitis that actually are precursors to development of a cancer. So what's the LINX? It's a magnetic ring manufactured by Johnson & Johnson. It got FDA approval in 2012. And since that time, there are more than 45,000 LINX implanted all over the world. It's basically a series of titaniums covered. Inside there is a magnet, and it's covered by titanium, which is inert material, and it's actually pull apart like a Roman arc. So it's pull apart whenever we have esophageal contraction that will open the LINX and then will close eventually. That will prevent the reflux. It comes in different sizes from 13 to 17. Initially, there was size 12, which was causing lots of troubles. So the peristaltic of the esophagus need to be 30 to 80% millimeter mercury, and the LINX will open around at 20 to 25. And actually, the gastric pressure, as we know, is about 5 to 10. So the patient selection, of course, it's been done for the typical GERD patient, no clinical significant hernias, although this has been challenged, and I personally implanted it, and worldwide actually implanted it in more than 5 and 6 centimeter hiatal hernias. No previous gastric surgery. Now we're doing it almost in most of the patient who has a reflux post-sleeve and bypass procedures. And we implanted it also in parrots as well as different patients with severe parrots like esophagitis class C and D. This is basically the initial recommendation of the company and the guidelines. But as I said, this precautions has been actually not valid anymore. So we did it in lots of other patients with precautions, and they do extremely well actually. So it's extremely important to address the patient and talk to the patient about the possibility of what the legs can do and how they change their life because of the dysphagia part and so on and so forth. And it's an integral part to have esophageal manometry for all the patient, because if you have a weak esophageal contraction, then the patient will have a bad dysphagia that might lead to removal of the device. Of course, you cannot implant it in a patient who has allergy to titanium, stainless steel, or nickel or ferrous materials. There is a caution with MRI after you implant it, because it's made of magnet, as we know. And as I said, the other parameters we're still working on it. Why we do LINX? It's a better standardized procedure, and this is maybe for our dear colleagues. We do Nissen fundoplication for years and years, and the way we do Nissen is varies according to the surgeon preference and lots of modifications. Versus LINX, it's a standard procedure, so you cannot go wrong with it if you have like 3 or 4 surgeons implanted it. It's removable. You could do it as an outpatient procedure. It's a laparoscopic procedure. It's require very minimum dissection, not like the regular fundoplasty. And the patient will have less complications in terms of inability to bleach and vomit after surgery. So this is how it looked like. After you close the hiatal hernia with suture, you implant it along the GE junctions, and you hook it anterior to the posterior vagus. So this is a case that one of the earlier that we did. Can we just move the videos, please, very quickly? Can we turn the one you're on? Yes. You can just move to like after 2 minutes, please. This is just dissection and so on and so forth. I know it might be good for our interventional gastroenterologist just to look at the hiatus and see how it looks like when they do the TIF nowadays and GERDIS. Control, can you move the videos to half of it, please? To the first half. Fast forward, please. 2 or 3 minutes. Yes, keep going, keep going. Keep going, please. Yes, to the mid. Just go to half of it. Yes, keep going, keep going. This is just the hiatal hernia, so you do the minimum dissection, then you close this hiatus. Keep going, please. If Ahmad see how I do the sutures, trust me, next day he's gonna do it. So this is this is the LINX. So basically we have the site, and then so basically there are a clasp around it, and then finally it will fit. All right, so we'll keep moving. So why LINX was actually get fought back when started in 2012 and 13, because the risk of the erosions. So we don't want to see these pictures, because the foreign body stay along the GE junctions and so on and so forth, and it has its own other complication like dysphagia, bloating, recurrence of the reflux, and migration as well. And removal of a LINX is extremely difficult for all the surgeons because it will form lots of adhesions. So we looked at the facts. I don't want to trouble you with lots of studies with that regard, but it's in 2022 it get approved by the by ACG, American College of Gastroenterology, and actually they consider LINX as better alternative to laparoscopic fundoplasty like Nissen. And again, it's get approved by many other international societies. And there are lots of studies about the safety of the procedures, about how it works. Even there are randomized control trials in 2018 done by Bell, which showed it's better control when it's compared to BBI. And there are tremendous literature support the resolution of the regurgitations after LINX, reduction of esophageal pH exposure, and the cessation of PPI up to 70-75% of the patient, as well as better quality of life after the procedure. One thing actually, which is a little bit scary to even to us as surgeons, is with the LINX migration or the LINX actually erosions, and what the literature support actually it's extremely rare. It's about 0.3%, and actually that was mainly in the earlier trial when they used the smallest type LINX. And we use it nowadays more and more often in bariatric surgery. We were one of the earlier center in the Middle East, actually, thanks to our Professor Mahmoud Shaheen and for his support during that time in 2019. We were the first among a hospital in the Middle East to implant the first LINX. This is what we have so far. We did 31 patients, 22 of them at our King Abdulaziz University Hospital. 22 of them they were post-sleeve. Their mean age, they were younger. Mean follow-up about 50 months so far. The mean BMI were 27. We implanted patients with actually larger, 3 patients with larger hiatal hernia. We had 3 patients with chronic complications. 3 of them, they developed dysphagia more than 3 months that required dilatation, 1 or 2 sessions. And I had to explant or remove 1 LINX due to migration. As I said, we developed with Johnson and Johnson LINX proctorship program. So we train surgeons in different hospitals to do the LINX procedure. So in summary, LINX actually is good alternative in managing patients who need surgical intervention for reflux. It's durable. It has evidence to improve elimination of PPI and normalization of acid reflux and improve quality of life. And the fear of LINX I think, was overrated. So that was my first part. The second part is going through this, and I understand from Dr. Ahmad and the organizing committees, they want to make it as a debate. So